Good afternoon, I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncology Expert. And today we are happy to be joined by Dr. Geoffrey Neuner, who's a radiation oncologist and vice chairman of radiation oncology at GBMC. We've taken a lot of questions from people who were asked about their interest in radiology, particularly when it concerns prostate cancer, a little bit about breast cancer. So we're just talking very broadly about radiation. If you could just tell us kind of what it's used for when we're talking about cancers.
So radiation plays a role in, the majority of cancer diagnoses. It's used as a primary treatment for cancers. It's also used as what we call an adjuvant treatment for cancers. So it helps some other definitive treatment work better. And it's used as a palliative tool if patients are having symptoms from a cancer that's never going to be cured. Say, spread of cancer into the bones causing pain. That's a very common indication for palliative radiation. So, in general, radiation is, throughout the world, is mainly delivered with X-ray machines, high-powered X-ray machines. And the way, traditionally, the way we think radiation works is it destroys the DNA of cancer cells, and that DNA, or those cancer cells, have a harder time repairing the DNA damage as opposed to your normal cells, which have those functions intact. And because of that, if you give a little bit of radiation day after day after day, the cancer cells accumulate enough damage so that they die, as opposed to your normal cells that repair and remain intact.
And of course, we were talking about before we actually started this conversation, but that radiation has been around for a long time, but it certainly has changed over the years, improved probably immensely in having less side effects or affecting other healthy tissue while it's doing its work, and being able to really pinpoint what you're trying to affect.
Yeah, so, it's been an interesting 120 years. Back, they first recognized the ability of radiation to help tumors over 100 years ago, and there was this great enthusiasm for it. It was put radioactive substances were put in things like shampoos and skin creams, and that was obviously not the right thing to do. I remember actually my grandfather died of a cancer that is very curable now, but I had a doctor's note from his radiology group in Washington, D.C. in the 1940s where they treated him with radiation, but they probably weren't able to give him the type of radiation he needed because he just didn't have very penetrating modalities. So now, we have very high-power beams that penetrate the body well. And we have computer technology, which has really changed how we give radiation over the past 20 years, in that we can basically, instead of looking at a target in the body and sort of trying to devise a plan with what we call forward iteration, we have a way of identifying a target, drawing the things we want to avoid around the target, and then plugging all that into a computer system which spits out a bunch of different iterations whereby we can spare normal tissue as much as possible while giving, often very high doses of radiation to target tissue.
Okay, we have so many questions from a lot of people who are really interested in what you have to say and of course, your expertise, so I want to get right to it. And the first one is also a pretty broad one, but how do you determine that radiation therapy is indeed needed?
So it depends on the stage of the cancer, the type of cancer, obviously the stage of the cancer. All of these things have indications. So, for example, in prostate cancer, someone with a high-risk prostate cancer, they have an indication for radiation as a definitive treatment depending on their age, comorbidities, urinary function and all that. In, say, breast cancer, radiation is rarely used as a definitive treatment for that, but it's more used as an adjuvant treatment, so after surgery, to make the surgical results better. And, you know, most women who get, say, a lumpectomy are candidates for adjuvant radiation to improve the local recurrence rate in the breast. So it really depends on the stage of the cancer, how the woman, the patients are, and, you know, the indication. So it is a very broad question. It's hard to.
Sure, it will depend on every individual case, but I guess I think we understand that you're speaking in broad terms. We just got this question in live from someone who is tuning in and listening. What is the collateral damage of radiation treatment versus surgery and chemotherapy? There's a two-parter, but it goes together. And is there a way to heal damaged skin tissue from radiation treatment?
So when we're talking about collateral damage, we need to focus in on where we're treating. So, you know, for example, if we use the prostate, for example, the two most important organs nearby are the bladder and rectum. And, you know, when you treat with radiation, those two organs can be damaged. Now, what has happened over the years is that we've done clinical trials to try and determine, you know, an adequate dose of radiation that will cure as many patients as possible while not inducing more than a very low level of chronic side effects in a population of patients. So, you know, that's what we do. In terms of surgeons, they have studied how to take out the prostate to also reduce those risks of side effects, though the risks of side effects, the qualitative risks of side effects are different. So, you know, in the prostate cancer, the risk is erectile dysfunction and incontinence of urine with surgery, but with radiation, it's urinary irritation, erectile dysfunction, and also maybe rectal bleeding and rectal urgency, for example. You know, how do you compare those two? You basically look at multiple studies and look at the occurrence rates of those side effects, and you try and present those in the most honest way to a patient so that they can make an informed decision on what might be right for them, notwithstanding, you know, their own factors which may put them at risk, more at risk for one of those side effects based on modality than another.
So it's obvious that too that the oncologist and the radiologist and the surgeon really have to work close together in making decisions because each one's going to affect the other.
That's right. I mean, we, you know, the way things should work in the cancer world is if a patient has multiple modalities that are options for them, those modalities should be explained in a very honest and detailed way so that they can make an informed decision. You know, I think the way medicine used to be practiced in the United States and where it is still, the way it is still practiced in other countries is that, you know, the doctor just makes a decision and something's done. Hopefully that's not happening here. But you know, I think giving patients choices is good, but there's also, you know, the difficulty of trying to educate a patient to the point that they're able to fully grasp what they might be facing.
Yeah, especially if they're really sick.
Yeah.
So the second part of that question was, is there a way to heal damaged tissue that's been affected by the radiation therapy?
So it depends on the tissue and what's going on. I think the example you asked was skin, so damaged skin. So if someone has, you know, typically when we treat breast cancer, for example, most women do get a skin reaction. Most women heal from that and go on and do fine, but some women, can get what are called telangiectasias, which are a scarring process of dilated blood vessels in the skin. It would be rare to have like a non-healing ulcer in the skin or something like that. So, for cosmetic stuff, that could potentially be taken care of with surgery. For something like a non-healing ulcer, either surgery or hyperbaric oxygen could be used. But I think in general, the answer to the question is, once there's damage to an organ by radiation, it's often difficult to heal it because it's basically a big scarring process in that organ. So we don't expect things to heal over time. But what we look at and what we try and counsel our patients on is what is the what is the quality of life of patients that undergo these treatments? How do they fare in the long run? Because although you could get some scarring, say, in your anterior rectal wall from radiation for the prostate, you may have no manifestations of that whatsoever for the remainder of your life. So, it's important that we have patients understand the risks of side effects which would affect them, like they would know about it.
Is it possible to develop new or different cancers due to radiation treatment?
It is. So that's always a risk that we disclose. That risk is dependent on multiple things, including age of the patient at the time of radiation and the dose of radiation. But it tends to be not very high. In most cases, the risk is less than 1%, and it's often like 1 in 200 to 1 in 1,000. But it does need to be balanced. So, in 10, 15 years ago, in the prostate cancer realm, most patients, I would say, with low-risk prostate cancer were being treated before we had great data on active surveillance. Now, 80, 85%, 90% of those patients are going on to active surveillance and are not being treated. But what you see in those trials of active surveillance is that, if you don't treat patients with these low-risk, low-grade prostate cancers, maybe a few of them will have their cancer get out of control. But in all these men who start off getting treatment, there are going to be a few of them who succumb to more often to some other disease process than prostate cancer. And what I think is going on there is that those patients are having things like cancer from radiation or, a heart attack within 30 to 90 days of surgery. So all these rare things that can happen from our treatments, they're much more important if there's not a great indication to give the treatment in the first place.
Those are some of the risks. What about the success rates of various radiation therapies when it comes to both prostate cancer and breast cancer?
So when it comes to prostate cancer, it really depends on the risk, the initial risk level of the cancer. So typically we have low risk, favorable intermediate risk, unfavorable intermediate risk, and high risk. And then you have, regional nodal risk, which is, very high risk. But typically in low risk, we quote a rate of cure, regardless of the therapy you get, of about 90%. With favorable intermediate risk cancer, that rate is about 85%. When it comes to high-risk cancer, that's when we start seeing a difference depending on what kind of radiation you use. So there was a trial that showed a benefit to doing brachytherapy, which is a way of putting radiation right inside the prostate using radioactive seeds. So if you do a combination of that and external beam radiation, it actually, high-risk patients have a disease control rate at 10 years of about 80%, 75, 80%. And if they only do the external beam radiation, the X-ray therapy, they have a disease control rate of about 65, 70%. So not as good. So we see some effect of changing up your radiation in that setting. When it comes to breast cancer, typically radiation tends to have the rate of recurrence. So whenever a patient comes in with, their breast cancer, we figure out their stage and the size and all that, and try and predict a risk of local recurrence in the breast. So this is after surgery. So if a patient has about a risk of 20% after surgery by itself, radiation probably would take that risk down to 10%. That's a very rough way of looking at the data, but I think it's actually a pretty good way of understanding it.
How many different types of radiation therapies are there, roughly?
So there are, there's X-ray therapy, which we talked about, brachytherapy. Brachy is Greek for near, so it means putting radiation right next to the cancer. And there's low-dose rate brachytherapy, which is, in this day and age, usually the placement of radioactive seeds into the prostate or other organs, but mainly into the prostate. There's high-dose rate brachytherapy, which is when you put catheters into an organ, and then a radioactive source comes out of a machine and sits in those catheters for some period of time, and then goes back in the machine. But that's another form of brachytherapy, and it can be used for prostate cancer as well. It's used for GYN cancers quite a bit. There's proton radiotherapy, which is not very common, but it is available near us. And that's a newer form of external beam radiation. So it's given with a very large machine. And the whole idea there is that, with X-rays, if I shoot an X-ray beam through you, about 80% of that X-ray is going to come out the other side. So if I have a target in the middle of your body, I want to take multiple different X-ray angles all around your body and sort of light up that target the same way we would light up someone standing on stage. With proton therapy, depending on the energy, at a certain depth in the body, all of the energy of the beam will be given off, and there will be almost no energy given off beyond that depth. So if you use various energies, you could cover a volume of disease at depth in the body. So it has a lot of benefits for places like the base of skull, brain tumors, paraspinal tumors, liver tumors. There's been some benefit. But it is used quite a bit in this country to treat prostate cancer. And, as of yet, there hasn't been any definitive data showing a benefit there. And then the last form of radiation we use is electron therapy. That's a very old form of electron therapy, of radiation therapy, which is a superficial treatment, usually used to treat skin cancers or superficial tumors.
Okay. What are the symptoms of prostate cancer?
So in this day and age, most people don't have symptoms. I mean, I think that's a dilemma for a lot of patients. They get diagnosed and they don't have any symptoms at all, and we're telling them they have a cancer, which often in the mind of the lay public means that they have a potentially deadly disease, and it could be that. But often they have no symptoms at all. In generations past, where there was no PSA screening, patients would show up with urinary obstruction, rectal obstruction, blood in the urine, pelvic pain. Those were all symptoms, but I would say we rarely see patients in that situation now, thankfully.
Could you talk a little bit about the PSA screening?
Yeah, so this has been an area of controversy for many, many years. For a long time, PSA screening was mandated, and then it was basically mandated that PSA screening not be done. And I think the latest iteration of the Preventive Health Task Force is that PSA screening can be done after an informed conversation with your, provider. So the PSA is emitted by the prostate. It can be emitted by normal prostate cells. It is very normal for the PSA to go up in men as they get older. It oftentimes will correlate with a prostate cancer, but it often doesn't correlate with a prostate cancer at all. And it can just be elevated for benign reasons. So it's, it's what we have to follow prostate cancer, but it's not great. So what was happening when everyone was getting screening, every year, we were diagnosing a lot of prostate cancers, but a lot of them are what we think are sort of benign, non-threatening cancers. And that's the whole, push in our field, is trying to figure out which cancers are potentially threatening to the patient in terms of mortality and morbidity in the future. So, typically what we look for with PSA is anything above a 4 is considered suspicious, but also a rising PSA, a consistently rising PSA, would be considered suspicious and maybe warrant a biopsy.
Do cancer patients or someone who's been treated for prostate cancer get a PSA after the fact?
Yeah, so, if they've had surgery, the PSA should go to 0. If it's not at 0, typically that means there's something left over, unless it's like at a very, very low level and stays stable for a long period of time. With radiation, it's more nuanced. Radiation kills cancers based on their growth rate. So prostate cancers grow slowly and they die slowly. So, it can take a long time for a PSA to sort of dwindle down to a low level, and it usually never gets to 0 after radiation. It can, but it doesn't have to. So as long as it stays at a low level and doesn't go up consistently past a certain level, we think the disease is controlled. So again, it's a lot more nuanced to follow the PSA after radiation to determine the effectiveness of radiation.
Are there particular risk factors for men getting prostate cancer?
Yeah, so, if first-degree relative has had prostate cancer, that doubles the risk. If there are, 2 first-degree relatives, that like quadruples the risk. African Americans have a higher risk of developing prostate cancer, and they tend to develop it earlier. That was reflected in the screening guidelines, at least in the past, where African American men were recommended to start screening at age 45 instead of 50. There are genetic mutations which can predispose patients to developing prostate cancer. So, it's very interesting. When I started, we didn't even think about doing germline genetic testing. Now, basically, almost all men with prostate cancer are eligible to get germline genetic testing. And I think the whole idea there is that the industries that provide these tests are trying to look more and more for the specifics of prostate cancer development and then create a tool from all that information. There's a regional risk to developing prostate cancer. So, North America and Western Europe and Australia have higher rates of prostate cancer than the rest of the world. There are ethnicity risks. We talked about African American men, and then white men come after them in terms of incidence. Asian American men have the a low incidence, and Native American men have the lowest incidence of all. You know, and then there are all these other risk factors that are, possibly linked. A diet that's high in dairy products. That's one that's sticks out to me.
I guess the typical lifestyle choices too. I mean, do they tie in smoking and overweight and that kind of thing?
So interestingly, smoking isn't necessarily a risk factor for the genesis of prostate cancer. There's some data to suggest that smokers have a higher chance of prostate cancer related mortality. That may just play into their ability to tolerate our treatments. But yeah, like a lot of those other things are kind of unconfirmed at this point.
Someone just asked this question. It sort of ties into what you said, but I see why he's asking it, or she. Is there a benefit to knowing your PSA number? Or knowing that it's low? Is this just to watch for change?
Yeah, I mean, again, it's a difficult, as a screening program, PSA screening wasn't thought to be that successful. So when you look at a screening program, you want it to be fairly inexpensive. You don't want it to result in a lot of morbidity for patients. And, you want it to make a difference in survival outcomes. There was some data showing a difference in survival outcomes. I think we definitely see patients present at a higher risk level now than they used to. But, it was in a very expensive program, and a lot of men were undergoing biopsies and getting treatment even when they probably didn't need it. So that's what the pushback was before. So the question of whether or not to get a PSA, I would say, you look at your age, you look at risk factors, look at the family history, and it's a conversation. How nervous are you about it? Some people, want to be screened and want to know, and I think that's totally fine. But I think as a just rote screening policy, we've kind of moved away from that.
Can you talk, you touched on this in the beginning, but just a little more in depth about how the team in radiation oncology sort of works together for each individual patient? And I think this is what makes the Cancer Institute so beneficial.
Right. So, we have very close working relationships with our surgeons and medical oncologists. Typically, the care of a patient is discussed in a tumor board before they get to our department or after they get to our department, but certainly before they're treated. And then within our department, we, when new patients are seen and recommended treatment, first of all, their treatment plan is reviewed by the other two physicians in the department to make sure that
All right, we've frozen up a little bit there, but basically Dr. Neuner was talking about how this is a comprehensive approach at the Sandra Malcolm Berman Cancer Institute, where all the experts get together and talk about each individual patient. I think we've gotten you back.
Oh, yeah. So I don't know where we left off, but in our own department, we review the indications for radiation amongst the, 3 physicians we have. And then the technical aspects of the planning are reviewed by a different radiation oncologist besides the one who planned the treatment. So there is a full QA process of planning that is done. In the old days, I would say that it was very much, the individual doctor knows best, and maybe this doctor does things totally different than this one. We've moved much more towards a consensus approach to patients.
And I also want to talk about how the community can support the Institute. There are ways to donate. I'm sure there are ways to volunteer.
Oh yeah, there's a never-ending need for patients for help at the cancer center. Much of the donations that are given go to an auxiliary fund that helps patients who have an inability to have no transportation or have trouble getting their medicines to get those things. So, they help us mete out the care these patients need in a more effective way.
All right. Dr. Geoffrey Neuner, I think we're out of time, and I really appreciate you joining us. It was so interesting to hear about your work in the radiology department and what is happening at GBMC. And I want to thank everyone for joining us today on Ask the Oncology Expert.